Thank you, Dr. Kanagal. You're too kind. I'm the one who learned from Rashmi. So it's actually a great opportunity to be here. And so I asked Dr. Kanagal what I'm supposed to tell this group of scientists, because I'm just like a translational leukemia physician that focuses in this relatively rare disease called myelodysplastic syndrome. And then she said, why don't you just tell us how we use kind of molecular data in our practice. So I think this is going to be hopefully an informative next hour or so. Here you see kind of like the agenda. So I was not sure about the audience. So I'll have a little bit of a brief introduction to myelodysplastic syndrome. I'm going to discuss with you this new molecular classification of MDS called the IPSS-M. I'm going to talk a little bit about clonal hematopoiesis, clonal cytopenia of unknown significance. I'm going to give you a vignette that to me is very important, that is this correlation of between comorbidities and mutations, how we used actually this kind of data for selecting therapy in myelodysplastic syndrome. And then at the end, that may be perhaps the most innovative part of the talk, I'm going to briefly talk about the use of optical genome mapping in MDS, and then, for instance, how we have used single-cell technologies, this is at the RNA-seq level, to actually inform sequentially our clinical trials. So I hope that gives you an idea of how clinicians use the data that you generate. So what is myelodysplastic syndrome or MDS? It's basically hematopoietic disorder, so a type of leukemia that evolves from a very primitive stem cell. Actually, that's why this disease is so difficult to cure, because it's very difficult to eradicate these cells. Clinically, this manifests as peripheral blood cytopenia, meaning they have a low white count, low hemoglobin, and/or low platelets. And these patients have an increased risk of transforming to acute myelogenous leukemia, although the reality actually is that most patients with MDS will die from a complication from the MDS itself. This is, in general, a disease of aging, so it starts in the 72, 73, 74 years of age. Now, there is this not rare type, there's this type that we call therapy-related. We'll be discussing that a little bit later. There are some genetic syndromes and so forth, but the majority of the patients with this disorder are in the mid-70s. And unfortunately, despite all our efforts, this remains a very poor prognosis condition. Now, this is very interesting because you guys are talking about all these technologies to sequence DNA in peripheral blood, these things that I just heard an hour ago. But the reality is that this disease still is morphologically diagnosed. And actually, this is very complicated for two reasons. Number one, for many cases, these are very obvious changes that even I, that I'm not a trained hematopathologist, can pick up, like counting blast, things like that. But some of the patients actually have very mild changes, and you need an expert hematopathologist like Dr. Kanagal to say, with certainty, this is a patient with MDS. And you are going to hear in a few minutes about this CHIP CCUS that is kind of like this border between being a healthy individual towards kind of progressing into one of these myeloid disorders. Now, this is so difficult, actually, that a number of years ago, we published this paper in Blood, where we showed, actually, that there's almost a 20% discrepancy rate between centers. And this is not MD Anderson versus a community hospital someplace in the middle of the United States. It's actually across the board. There are many reasons why this happens, maybe timing of when these bone marrows are done, and there are other explanations. But it gives you an idea of how important it is to have proper diagnosis, because actually on this paper, what we showed is that the majority of the patients were actually upstage. People were kind of maybe at fewer blasts, and then when they went to a tertiary care center, their disease all of a sudden changed. That meant therapy changed, prognosis changed, basically all the interventions around them changed. This is something that I'm not gonna talk about now, but it's also quite controversial, because there are two, you may know about this the WHO classification, there's this group called ICC, and they're kind of not agreeing in terms of how we characterize at the morphological level this condition. So this is actually complex. The point of all this is it emphasizes actually the need to have objective molecular data actually to maybe call these diseases. The disease is extremely heterogeneous in terms of prognosis. So for many years, basically since the mid-90s, there's been an effort to develop prognostic systems, and this is really important. The first one was called the IPSS. I'm not going to discuss it in any detail. And then around 13 years ago or so, was actually updated into the so-called revised IPSS. This is kind of like the standard tool that we use to prognosticate our patients. If you look at this table, you will see that the characteristics that we look are basically two types. One, you could call it molecular data, that is basically conventional cytogenetics on top. This is actually very important in this disease, so the prognostic weight that comes from this analysis is really important. And then you have kind of the so-called clinical characteristics, percentage of blast, level of hemoglobin, white count platelets, and then you put that together in this very simple table, and then you come with a scoring system that will basically divide these patients into what we call the very low risk towards the very high risk, and then you basically can think about the survival is whatever, as you can see in this Kaplan-Meier plot. This is very important. We actually use this in the clinic to basically inform our patients of what the expectations are gonna be, okay? And this is kind of used all over the world. The reality is there's no actually good access to cytogeneticists in probably most countries outside the United States, well, North America, maybe Europe, and some places in Asia. Actually, believe it or not, this technique is complex, and I will be talking a little bit at the end when I go through the optical genome mapping. Now, before we had these kind of tools at MD Anderson, we had this kind of very simple dichotomy where, I mean, I was on a very junior faculty here, but Dr. Estey, that died a couple of years ago, who was one of the leaders in this field, you know, he will divide patients into more or less than 10% blast. And this was our meeting. So at that time, we will say, oh, patient has less than 10% blast, they can go home, nothing to do. Or patient has more than 10% blast. In those days, we had no therapies. We'll give them some AML-like therapy. So that was actually 1999, 2000. Then people really started working hard on this model. So the IPSS, the Europeans had this WPSS. MD Anderson developed a global model, a low-risk model. I'm going to discuss the comorbidities a little bit later. And then you just saw the revised IPSS. So how did this IPSS happen? Actually, I think Dr. Soler is in the room, and he was a significant part of this effort. So people started to realize that, you know, the way we had characterized this cytogenetics in very simple kind of three groups for the IPSS was actually underperforming. And this is a very interesting paper from the German group by Dr. Haas, that you may know. He's also a very well-known cytogeneticist, where you see that the median survival time, this is actually the error bar in your analysis, can go from like plus 20 mass to plus minus 26. You will never publish a paper with this kind of data, right? But this is basically how we were assessing risk. We had a big kind of variance depending on whatever characteristic. So that basically promoted this effort to really look into quite a bit of detail in terms of cytogenetics. So this is an effort from Germany and then the Anderson group, and this is very important for the group. If you look at the table, you will see that it says category poor, 7 months, complex blast. So in the past, all our weight, as you saw from that initial slide, was on the percentage of blast. So 20 to 30% blast, median survival 7.5 months. But if you pay attention in the middle, it says complex 5-7, complex non-5-7. The survival is actually worse if you just look at cytogenetics. And actually, that's independent of the percentage of blast and cytopenias. So for some reason, actually, this is very common for all leukemias, but particularly myelodysplastic syndrome, the prognostic information that you derive from this kind of data is very fundamental. And that actually led to this scoring system where Dr. Soler, that I think spoke yesterday or the day before, was a key member, where they developed this cytogenetic scoring system. And what you see there is that it goes from the very good to the very poor. This you cannot really memorize, so there is an app on the phone that you basically like click and it will give you the vector. So we were going through all this. And then around 2010, we had a PO1 grant with the Dana-Farber, with Ben-Eber, Rafa Bejar. We started doing a little bit of the early genomic analysis in this disease. And I know Dr. Di Persio talked here maybe yesterday, the day before, and I remember the first time I met him. He's like a great leader in our field. This is around 20 years ago. He had some slides of the sequencers at WashU, across the street. And I was thinking, what is this man talking about? Sequencers and the Human Genome Project. So he was such a visionary, because 10 years later, actually, this was like actually very rudimentary sequencing technique called 454. Probably nobody knows what that is, right? That's like the old technique. But we started actually putting together the first maps of molecular alterations in MDS. And this was very interesting, actually. There was a New England Journal paper that probably today will not be even publishable or in a very small journal. But what you see there is that you had the group of patients with the P53 mutation, and then kind of the others. And it was very interesting, actually, that those patients with P53 mutations didn't really have a lot of other mutations. The theory is that maybe cells cannot sustain having a lot of very strong genomic alterations because maybe they'll die. So we started to see this molecular cartography of this disease, perhaps associated with different prognosis. I think this kind of effort really pushed for a lot of investigators trying to sequence and identify the MDS gene. Unfortunately, this not happen. But you saw data like this. It's from Eli Papamanuel when she was in Cambridge at the Sanger, and they were identifying, in this case, the most commonly mutated gene in this disease, that is a splicing-related gene called SF3B1. Okay, and if you pay attention to the bottom Kaplan-Meier on the bottom left, you will see, for instance, that that particular gene is associated with very good prognosis in the right context. So we started to see maybe that there was an opportunity for gene discovery and maybe to really expand our way to molecularly annotate this disease. And eventually, 3 or 4 groups around the same time, this paper, I like it because it has a very simple slide, came out with this kind of classification or what I call the molecular cartography of this disease. So these are basically the most commonly mutated genes in this disease. What you see there is number 1 is SF3B1. And then what is interesting is, I don't know if this has yeah, if you can see here, actually the question is, those kind of low frequency events, are they really part of the disease or they just happen to occur through this disorder? Now, Dr. Soler is gonna like this because if you pay attention here, actually in pink, you will see del5Q, del7, blah, blah, blah. So actually these investigators did not remove or abrogate the cytogenetic data. The truth is that when we were thinking about incorporating this kind of data, we thought cytogenetics is going to disappear. And actually, it has not. Actually, in this kind of analysis, it remained as one of the key molecular features. To me, this is very interesting because perhaps what it means is that these large chromatin structural changes, they have some other biology. So it's not just like the technique that they're using to detect this phenomenon, it's that they're actually reflecting different biology. So we started looking at this from a classification or prognostic angle very quickly. There's a paper that we published with Rafa Bejar more than 10 years ago. This is actually looking at what we call the low-risk group of patients, and we knew that those patients have also very heterogeneous prognosis. People can live for decades. Some people with this so-called low-risk disease are dead a couple of years later. So we built this model that you see here, looking at different mutations, and here the example is, for instance, how in the context of a classical classification, that is this low-risk MD Anderson model, mutation on EZH2, a gene that is somehow mutated in this disease, really changes the outlook of those patients. So we started to see that you could really characterize those patients using this molecular data. This is perhaps an easier way to look at that data. This is actually looking at the number of genes mutated in this particular disorder. So in blue, you see the patients with SF3B1, that is the only one, that is good. In black, you see no gene, 1 gene, 2 genes, etc. And again, this data is actually independent of percentage of blast and potentially cytogenetics. So this is very interesting. As we start accumulating this kind of molecular damage, you have a worse prognosis. Now, there is complexity here. One is actually the codon. This is nice work by Dr. Kanagal, where she went deep into this SF3B1. We call it all good, but it turns out actually that maybe only one of the codons, this K700E, is really associated with a very good prognosis. Maybe the others are not that good. And of course, I'm not going to go through this today, is this issue of the variant allelic fraction. Today you're talking about sensitivities of like 0.5%, things like that. In our practice, I don't know, is it 5% for most of these assays, 2%? But the question is, does this have an impact or not? And we're starting to understand that indeed, actually, it's not the same to have a 30% BAF versus a 2% BAF that is barely detectable with the CLIA techniques that we use in our labs. This is another example of this kind of analysis. This is by Dr. Montalban in our center, and this is actually, I think, eye-opening. So for instance, this is the IPSS-R, high, very high. The worst and most frequent mutation is TP53. I'll give you a couple of vignettes in a second, so very bad. But then actually, if you have more than 3 mutations, your HR is close to 3. So it's as bad as having a P53 mutation. And it's not uncommon, actually, and I'll give you a clinical example at the end, of having people with 5, 6, 7 mutations with what we call low-risk disease and poor response to therapy. So all this actually led to this international effort called the IPSS-M. This took a long time. And it's actually validated in the context of no therapy, but it's not clear if it's actually validated in the context of therapy, particularly hypomethylating agent therapy. But this is a really important tool that we use in the clinic now all the time. So what is this? So this IPSS-M, I don't know if you can see that, is basically like the IPSSR, so the same characteristics, the same cytogenetic vector, plus genomic information. And it has a really first step that is kind of calling the P53. And then you move to like 16, 17 other genes in this classification. This is actually for free in kind of the internet. Go to Google, you put IPSS-M, it takes like 10 seconds. And it will give you actually in parallel the IPSSR and the IPSS-M. Now, what happens with this is that I think it's a nicer classification because we refer to this as symmetric. So the IPSSR has 5 groups, so it's difficult to say what to do with the intermediate group. Here, what you have is from the very low to the very high, and then the intermediate is divided into these 2 groups. So this is very powerful, okay? And this is now through multiple continents. I think they are not in the classification itself, but in this database, around 7,000 patients and so forth. So really powerful data. And this is what we use at MD Anderson, probably here at WashU, et cetera. The issue is that this kind of genomic data is not used through the whole world. Another question is, what classification do we use? IPSSR, IPSS-M, you use both. Now, they are not the same. So this is from this New England Journal of Medicine evidence by this group that developed the IPSS-M. And what you see here actually is that if you put in these tables IPSS-M against IPSSR, actually the IPSS-M implementation, so the use of genomic data, upgrades or upstage the prognosis. So people that could be low risk by IPSSR, now they have moderate to high risk, and so forth. So accumulating mutations will basically worsen the prognosis of your patient. So this is kind of complicated, right? Because you see this patient maybe with a benign kind of profile, low blast, not really bad cytogenetics, a bunch of mutations, that's poor risk. And then you look at them by IPSSR, this is like a low moderate, by IPSS-M now this is a moderate high. And you say, why is this important? Well, your therapeutic decision is going to be made on that. Does the patient need a bone marrow transplant? Does this patient need some form of intensive chemotherapy? So this is going to really affect how we change our outlook. Now, this genomic data also resulted basically in the identification of these 2 conditions. I don't know they are diseases. One is called clonal hematopoiesis of indeterminate potential. You know, I don't have any idea why. Maybe Rashmi can explain this to me. A healthy person gives blood and then they find a T2 or the NNT3A mutation in their peripheral blood, but that's basically cheap. CCUS is more advanced. In CCUS, you have a cytopenia, you do these tests, and now you find these mutations. Now, this is actually becoming one of the most frequent referrals to MD Anderson, actually, because we tend to evaluate these patients with difficult to diagnose conditions, thanks to the expert hematopathologists that we have in the center. Now, we used to call this ICUS, idiopathic cytopenia of unknown significance, meaning we had no idea what you have, your cancer is a bit low, nice to meet you. Then we started doing this kind of mutation profile, and then we kind of freaked out because now we see these individuals that are otherwise healthy without MDS or without any other leukemia that have this kind of mutations. So the group at the Dana-Farber with Lachelle Weeks and Ben Ebert are doing a great job here because they're really helping us understand from clinical perspective, perhaps, the trajectories of these patients. So this is looking at this large UK database, and what you see is that the most frequent mutation is the NNT3A in 60% of the patients, followed by T2, XL1, and then the others. And then basically what they also showed from this sample is that those patients with the NNT3A in green, they actually probably have a natural history that is similar to like a normal aging individual, whereas the others may be a little bit more serious. This is helping us a lot because, you know, in the past, we didn't really know what to do with these patients, right? Should I see you every 2 months, 3 months? Never. So perhaps those patients in green, they can be followed by a primary physician or a community hematologist. Perhaps those over here, they need to be watched more closely. And actually, at the end, if I have time, I'll show you an example of preventive therapy for this group of patients with this kind of disorders. This group also at Harvard has developed this CHRS, that is basically a risk scoring system where you can put the type of mutation and so forth and actually predict what will be the behavior of this disease. Now, clonal hematopoiesis is very rare in people younger than 50, so this is total aging phenomenon that manifests, you know, around 50, and then it peaks around basically in the 80s. Now, yesterday, I saw a lady from Mexico who's 51 with classic DNMT3A mutation, and her question is, what is my prognosis? I said, well, your model says you have a very low risk, but you're very young, and you have maybe 30, 40 more years if we keep aging this way to develop this kind of disease. So I think this is going to be very interesting to see how we follow our patients. Now, something that may be exoteric for you, but at the beginning someone was talking a very nice talk about peripheral blood, very sophisticated molecular assays, is the correlation between these molecular events and comorbidities. So for many years we said, well, people with MDS, they're older, therefore they have a higher tendency to develop heart disease, atherosclerosis. We thought it was just kind of coincidence of aging. It actually may be more complex. So this is a very beautiful paper from the group at Yale. Now, it's a classic old paper, but very important. And what they found actually is that, for instance, monocytes, these are mouse model of clonal hematopoiesis plus coronary artery disease, these monocytes that are of bone marrow origin, so hematopoietic origin, and in this case mutated for TET2, actually are the cells that migrated to the coronary artery bed and maybe cause local inflammation, therefore causing atherosclerosis. So actually, the disease-causing cells are of bone marrow origin. So this actually opens this concept that perhaps actually this is not just a coincidence of being old. It's a fact that these diseases actually are really syndromes. That's why I'm so upset with Dr. Kanagal and her colleagues, where they switched the name of MDS to MDN, because it's not really a neoplasm. It's actually a syndromic process. Why? Because these cells go to other tissues, and now they cause these problems, for instance, in the heart or the liver. Why is this so important? It is very important because when I treat this disease, am I treating a cell that is just residing in the bone marrow compartment, or I'm treating cells that are actually through the tissues of these patients, perhaps causing local inflammation? And perhaps when I treat and improve the survival of one of my patients, what I'm doing is maybe modifying the tissue architecture in the heart, maybe just more than decreasing the percentage of blast in the bone marrow. This needs to be studied. Now, a number of years ago, we did an analysis that I think is very simple, where we basically look at the correlation between mutations and disease, okay? And we used a scoring system, a comorbidity scoring system that is called the ACE27. It looks at 27 comorbid entities, so heart disease, diabetes, hypertension, these kind of things. And I think the results of the study are really illuminating, because what we found was that this is not an stochastic process. Indeed, actually, we saw the reverse. We saw that there is a tight correlation between the type of comorbidity that you develop and the type of mutation that you carry. Now, this paper originally was criticized because we could not find, this is only a 900 patients, so it's not like a huge population study, but we could not find correlation between TET2 mutation and cardiovascular disease, but we found it with DNMT3A. We found, for instance, JAK2 mutations being occlusive disease, P53, of course, therapy-related, but also pulmonary disorders and so forth. So this is intriguing, because if the studies could be enlarged, we could actually maybe predict the type of comorbidity that these patients could develop if they have a particular mutation. So this is something to follow. Let's move on in terms of how we use this kind of data in terms of therapeutic decision-making. So for years, and still today, the hallmark in leukemia is to achieve a complete cytogenetic remission. So you need to bring down the blast, you need to recover peripheral counts, but then you go deeper. And the first step, and actually the most important step, is to demonstrate that that clone has disappeared. Typical example in MDS, for instance, this is called del5q minus MDS. This has typical morphology, has this typical cytogenetic alteration, and most important, has a very effective drug called lenalidomide that we have for like 25 years. And what we see in these plots is that those patients that achieve a complete cytogenetic response are the ones actually that will go and live for a long period of time. So, this is maybe a trivial example that if I had been invited to this meeting 5, 6 years ago, where we didn't have half of the data I'm showing today, it would be the actually only example of any kind of therapeutic decision-making we had in these disorders. But then we started incorporating the genomic data that I showed you earlier into our CLIA lab, and Dr. Kanagal has to be congratulated because she and her colleagues have really done a phenomenal effort. I mean, the Anderson, we get this kind of data depending on their mood in 2 days, sometimes a week. Anyways, we get it quite fast. And this is a slide that she gave me, and what you see here, this is what we call the 81 gene panel, okay? And then I started putting these boxes into the genes that actually we really think could have value. So let's go through this very quickly. XL1, this may be a predictor of activity. I'll show you an example of a drug called venetoclax in this group of diseases. IDH1, 2, these very powerful targeted agents that block this. DDX41, this is really interesting story. This may respond to lenalidomide. It's also a very important familial syndrome that we see occasionally in this group of disorders. I'm going to talk a little bit about SF3B1, and I'm going to talk a little bit about P53. So this is actually how we see that this is so important, and listening to you, and the fact that perhaps in the near future, very soon, we may be able actually to move this into peripheral blood only. It may be that at some point, actually, we don't even need to do these bone marrow assays, and we don't really need morphologies. It could be possible that perhaps peripheral blood cytogenetic assays that I'll discuss in a second, maybe some of these molecular assays could be just enough. So let me give you an example. So we don't know if this drug is going to be approved or not. We should hear from the FDA in the next couple of weeks. But this is a drug called luspatercept that is a TGF-beta modulator that is active in patients with myelodysplastic syndrome. So this is from this large randomized study, 60% response rate versus 30% response rate. But basically what we see is that their response may depend on this particular phenotype that we call ring sideroblastic anemia, that, as you hopefully know, for those of you that are hematopathologists, universally is characterized by mutation on this gene called SF3B1. Indeed, actually, the new WHO classifications have removed the morphology and incorporated, if I'm correct, Rashmi, the mutational status of this particular gene. So this will be another example of a drug that may be quite effective for our patients. Now, in this group of patients, actually, we're starting to see that perhaps the genomic architecture of these patients with MDS, basically what we call here like the genomic burden, may be very different and may dictate actually whether patient responds or not to this particular type of therapy. In this case, for instance, what we call an erythroid-stimulating agents that are very commonly used drugs. In our group, we're developing what we call total oral therapy. So these are very effective, kind of probably chemotherapies, hypomethylating agents, BCL2 inhibitors, but these are totally oral compounds that are extremely effective. So this is an oncoplot. This was at IHA in Frankfurt like a few months ago. Sorry. And what you see, if I can go back, is basically the genomic distribution. But if you pay attention, we kind of selected this group of patients with this XL1 mutation because we knew from some preclinical data that they could be very sensitive to this kind of intervention. And indeed, actually, this group of patients have almost 100% response rate to this kind of therapy. In contrast, these patients, TP53, that were quite substantial in this trial, they actually don't seem to benefit from this kind of therapy. So this is very important because in the future, actually kind of now, we're starting to select, I want to give this kind of BCL2 combination for this XL1 mutated type of patient versus I am not going to do this in this TP53 mutated patient because the only thing I'm doing is basically causing more cytopenia. This is just to give you an idea of the responses. So the overall response rate in the overall group around 95%. These are like unheard numbers, figures that we, compared to what we had a few years ago. And part of this is because we can really select out the group of patients that we want to treat. This is another example. This is basically the survival, so I'm going to skip. Now, let's talk about the major problem that we have right now. This is the TP53. So we don't really have any good drug here. If you have this disease, this is very complicated. So this is looking, for instance, standard of care, whether you have P53 mutation or not, and the survival is in green around 11 months. We've done study after study after study, and we cannot beat this kind of less than 1 year survival. So this is actually very sad. And this is the group of patients with what we call therapy-related disease. So people that had some other cancer, they get chemo radiation, and then years later, they go and develop this disease. So this is a major problem. Now, I may not have therapy. I will push for a clinical trial, but this may guide me in terms of perhaps, should I offer a bone marrow transplant or not to this patient? So this is data by Dr. Coleman Leslie at the Dana-Farber, beautiful study, for instance, looking at outcomes post-transplant in this group of patients with this particular mutation. So it's incredible, actually, because these patients go, they have a remission. We go and we do a bone marrow transplant. But then we know that if they have this particular mutation, they have almost a universal rate of relapse post-transplant, and then they go and they pass. So the question is, should you do this bone marrow transplant or not? This is complicated, and this is probably a talk in itself for some other type of investigators. But to give you actually the power of this kind of data, because this is what we discussed. Patient has poor performance, maybe the donor is not that good, and has a very adverse molecular feature. Should we proceed with this very aggressive total therapy that is quite complex and expensive, actually, for our patients. So this may not be the right way to use this kind of data in the sense of a positive outcome, but maybe this could be the way of sparing patients from this kind of very aggressive approach. Now, let me give you a positive view, NPM1. Now, this disease, I heard Dr. Hasserjan talk about this, right? But we beat the Boston group by a few months in this particular context. So we actually discovered this. And it was very simple. So I started seeing young patients in my clinic with this MDS, with this particular mutation called NPM1. And I thought, why should I treat these patients with conventional myelodysplastic syndrome type therapy that in blue is what we call a hypomethylating agent. So I asked why we cannot treat these patients with AML-like therapy. And if you're familiar with this type of diagram, this is the survival plot. So if you treat these patients with the right therapy in red, the cure is almost universal if you follow that actually with a stem cell transplant. Now, we call this NPM1 MDS. Now, the new classifications are, I don't know to understand why, they're changing, they're incorporating therapy into how we call diseases that I don't think is right. But anyway, so now this is actually in the spectrum of acute myelogenous leukemia, which is totally fine. Unfortunately, this is 1% of MDS. But let me tell you one thing. You see, like in our center, maybe 500 patients a year. That may be five patients that I can cure if I pick the right assay. So in the community or whatever, the physicians are not retrieving this kind of information, or if they get it a month or two later, and then you say, oh, by the way, this person had this NPM1 mutation. Well, if you are the patient, this is a big deal, because it was 0.001. So like, yeah, this is fine. But actually, we see these patients all the time. Now, they have particular morphology. Many times they are like in transit to like acute leukemia. But this gives you actually the power of identifying these kind of alterations in this disease. Now, this is another example, extremely satisfactory. So this is a mutation that is common in this kind of disorders, IDH2, around 10%. There's a less frequent one called IDH1, maybe 5%. So these drugs actually are approved for acute myelogenous leukemia. So we have a major problem in this disease called hypomethylating agent failure myelodysplastic syndrome. So this is basically second-line therapy. So once you fail, your patients never fail therapy, the doctors fail. When we fail these therapies, outcome of these patients is actually survival of around 4 months or something like that. So it's really difficult situation, and there's not really good curative alternative. It turns out actually that if you have an IDH2 mutation, this is for the second-line relapse refractory patients, the survival in these trials actually is now around 22 months or so, and getting better. So this is quite incredible, and this is actually with monotherapy with this particular inhibitor of this mutation. Again, if you do not check for this type of mutation at the type of relapse, this is actually a problem for your patient. And you say, well, it's 10% of the patients, but I mean, you start adding 1% here, 10% there, 5%, then all of a sudden you have 30, 40% of the patients that are informative. The other issue with this genomic data, and this is a discovery from here from the WashU group by Matt Walter, is that these are very dynamic. So these are not static, meaning just because you have whatever profile at baseline, it doesn't mean that you're going to have the same profile at time of relapse. Indeed, actually, this is this famous fish type of diagram. But what we found a number of years ago was this issue. That is and here actually the paper got rejected because I used the wrong word, because we call it acquisition. And maybe it was emergence. I had no way to prove this. But basically, what we wanted to say is that these patients that were not FLT3 mutated, this is a commonly mutated gene in acute myelogenous leukemia, very rare at baseline in myelodysplastic syndrome, but actually is seen in around 15 to 20% of patients with proliferative high-risk myelodysplastic syndrome. This becomes really, really important, as you will see in a second, because all of a sudden, this is very old data. You can go from a lethal diagnosis to a situation where you have maybe a 50% response rate and the possibility for survival. So this is another very important aspect, how these actually are dynamic events. So you have to keep checking. Now, we fight with our friends here because sometimes they block us from repeating these NGS assays. I think they are expensive, and the FDA regulates how we use this kind of data. But this is kind of important, making sure that you're really asking the proper test at the right time in the natural history. I am not going to go through this because I cover it, but this just gives you an idea of where the field is going in terms of specific cytogenetic and molecular alterations in this disease. Now, the next part of the talk, and I think I have 20 minutes, I'm going to tell you about two things that are kind of very important. So the first issue is this topic of optical genome mapping, or this high-resolution structural variant profiling in MDS. So this is a technology that Dr. Kanagal brought to MD Anderson in collaboration with BioNano, and now actually is in the CLIA environment at our institution, and I believe also going through other centers. Now, I think this is really important technology. I'm not going to go into the details. Basically, I don't really understand the technology, but that I'm sure has been discussed. But I think what is very important here is two issues. One, you don't need to grow these cells to obtain metaphases. That is actually something that happens in around 15 to 20% of, maybe around 10 to 15% of our MDS patients. The second issue is that you don't need an expert cytogeneticist that can really read metaphases. That I think is the rate limiting step in many laboratories. Now, I'm not saying this technique will replace conventional karyotyping, but I think this technique is really important in the sense that it may allow us to uncover cryptic alterations that we don't really see with conventional cytogenetics. And I think actually this may sound kind of strange, but I think may democratize cytogenetic evaluation in places, in countries actually where they don't have access to this kind of technology, because at the end of the day, you just have to have this device, you have to have access to high molecular weight DNA chromatin and then put it through this process. So I think this technology that is going to be quite helpful. So this was first published in Leukemia in 22. I'm very proud of this paper actually, because we were kind of like the first to push this technology in MDS. But the reality is, I think this is going to be as important in acute myelogenous leukemia and in acute lymphocytic leukemia. These are the diseases that I know, and probably other tumors, because of this issue of translocations, fusions that we heard earlier, that are actually not very common in this disease. Now, this is important because the fact that we don't have what we call insufficient metaphases, that is kind of failure, and the fact that this is really robust technology, actually similar to the IPSS-M versus IPSS-R, actually upstages or changes the classification in 20% or so of the patients. So this is very important. So you see here the diagram how it does work. So this is really important. And in the future actually may allow, for instance, for the identification of new KMT2A alterations that we think are very rare in this disease, that maybe are a little bit more frequent. And why is this important? Because there are actually drugs in that particular context that could be quite effective. The last word on this technology, and this we are investigating, is the fact that we think that this could be done also through peripheral blood. Now, in myelodysplastic syndrome, you need to do this painful procedure called a bone marrow aspirate with a biopsy many times, where you retrieve that bone marrow material, they look at it in the microscope and so forth. But at EHA, the European Hematology Association meeting in June, a couple of months ago, the European group in Austria showed data from thousands of patients where they had done peripheral blood NGS, and they found actually an almost perfect correlation with the bone marrow results. So then the question is, do you need that? So I asked Dr. Kanagal, could we do the optical genome mapping actually in peripheral blood? It looks like we can. So we're actually trying to validate that. But I start seeing that in the future, actually, we may move to potentially an approach where we perform diagnostic or prognostic type of scoring approaches to our patients just from peripheral blood. That actually could be quite incredible if the price of these technologies are acceptable. And then allow me to, in the next few minutes, and I think we'll have time for questions, to see actually where that I'm not a pathologist or a molecular technologist like most of you, hope to see the field going. That is actually incorporating single-cell technologies in the CLIA space. Now, we do not have experience with mutational data at the single-cell level, so I cannot show you that. But I'm going to show you an example of a trial that we're conducting at MD Anderson where we use single-cell RNA-seq to hopefully in the future inform the study and actually monitor what happens to our patients through therapy. So this is data from Dr. Simona Cola and Irene Gayan in our center. We're looking at, for instance, these single-cell maps, in this case in CHIP CCUS. So this is very interesting because we can characterize actually different cellular compartments, what their molecular pathways are, etc. So we thought that perhaps this could be a technique that we could deploy in the context of a prospective clinical trial. So for a long time, we've been interested on this compound that modulates or inhibits, blocks this molecule called interleukin-1. Why is this important? Because this interleukin-1 is a key inflammatory effort. Actually, this is probably through many different tumors, but particularly in myelodysplastic syndrome, this is a key effector. So the hypothesis is that if you block this IL-1 signaling here, you may actually somehow inhibit this kind of NF-kappa B mediated inflammatory signaling that we think inhibits hematopoiesis in patients with lower risk myelodysplastic syndrome. So by doing that, basically, you may improve the capacity of these patients to really form white cells, hemoglobin, and platelets. So we designed a clinical trial with 3 different cohorts. Now, the FDA, at the beginning, only allow us to treat patients with what we call second-line low-risk myelodysplastic syndrome. So their argument was, you have never used this drug in patients with CCUS. That actually I could have because I'm over than 50. Maybe a couple of you, say, why would you treat me with a drug? I don't need anything, right? So the FDA was concerned about the safety of this issue, and also there are good therapies for frontline low-risk MDS. So I'm going to walk you through, hopefully this will explain what I discussed in the last 40 minutes, how we're starting to use this data in context. So this is the design of the trial, how we do this, the type of rule, the eligibility criteria, not very important. Okay, but this may be of interest to you. So at ASH last year, we presented data, I think it was in around 20 patients or so. You see their median age was around 75 years. That is kind of the standard average age for this disease. This is a disease that is more frequent in males than in females. Okay, very common. This is low-risk disease, so they have a low percentage of blast. And then we started looking at the data. Okay, cytogenetics, because this is so-called low-risk disease. Most of these patients are diploid. Very few of them will have really a bad abnormality. And it's actually very uncommon that they will have complex karyotype. This means that they didn't have any other alteration. But this is very important because when we start putting the molecular data, the study that is for so-called lower risk patients, and we now put the IPSS-M, what you see is what I told you at the beginning, that is now we are upstaging these patients. So indeed, actually, okay, very low, 4%. This is actually the group that we intended this therapy, not the ones that I'm going to show you next. Low, 22%. Moderate low, 31%, but then we go high, 22, high, 17, very high, 4. So actually, if you do the math, it looks like 40% of these patients, if you just look at the molecular data, have actually high-risk disease or higher or poorer prognosis that probably should not be treated in a study like that. Now, to my knowledge, this is kind of like the first prospective study where this kind of IPSS-M data is put, but it gives you an idea of what happens here. And you know why is this so important? Because we're tired of our clinical trials failing. We do these big studies, randomized, 500 patients, this drug versus the other, failure after failure. Why? Because we're not segregating at the molecular level correctly. We're incorporating this high-risk P53. Here, I have a study of low-risk disease where actually almost half of the patients have high-risk, poor-risk molecular features. Maybe in the future, we should really try to avoid this. The drug is very well tolerated, but wait a minute, the response is very small, 16%. So this goes again to the trash can. Another study, a few $1 million wasted on a clinical trial with no activity. But let's look at the detail of, actually, this may be of interest to you. This is the survival of these patients. What is it? Survival probability, 13 months. Can you tell they tell you have low-risk disease, but your survival is like 13 months? I don't know. I don't think that's something really acceptable. But let's go then deep into the molecular characterization of these patients. So in the green rows, these are the 2 individuals that actually had an incredible response. They're actually transfusion dependent for longer than 1 year. So if you look at them from a molecular perspective, number of mutations, 1, TET2, DNMT3A. Look at the non-responders, 4, 3, 5, 8 mutations. So these are patients actually that are totally different in terms of the molecular composition compared to those that really responded to the therapy. So to finish, actually, let me walk you through the visualization of what happens to these patients. So this is one of the patients that had a really good response. And what we do here basically is to base each color on this diagram is cycle 2, cycle 4. So we're putting basically the composite of those cellular events through the course of this therapy. So this is in this pie diagram here, this is how hematopoiesis looks in these patients before don't remember he or she, received this therapy. And what you see actually is that there is a gigantic expansion of the HSCs, the stem cells, because this bone marrow is trying to overcome these difficulties it has in this case of producing a hemoglobin. Then we start therapy. And then what happens? This actually compensates, because now this patient is actually maturing, not the patient, the erythropoiesis, and now the patient has a very excellent hematological response. So the stem cell doesn't really have that pressure anymore. That's really interesting. And then we go and see, okay, in these maps, what is the IL-1 receptor that is kind of like the target of the particular medication that we're giving? And it's actually in the compartment where we expect it to be, that is in the HSC. So in my mind, in the future, if we can put this kind of molecular data saying this patient indeed actually has low risk by these molecular features, and we could perform this type of assays that are actually not that complex, actually not that expensive anymore, would actually visualize if that particular patient has the target or not. Because if you follow this patient sequentially, I think it's in the next slide, what you will see, first of all, is that in the HSC, we find the pathway, and I don't know if you can visualize that actually here. What you see is that we start treating, then the intensity goes down, and then eventually by cycle 14, this patient starts losing response to this therapy, and it reappears. So actually, we could use this kind of RNA single-cell data to really guide our therapeutic effect on those patients. That is quite phenomenal, okay? So this is looking at the same thing, but the prior example was selecting these CD34 positive cells. Here, just looking at the full population of mononuclear cells. And what you see basically here is that now you have nice, healthy erythroid population, reflecting the fact that now you have a functional maturity in that part of context. So this is actually in contrast with the patient that did not respond. It's an extreme. So this patient, look at the complexity at the molecular level. What happens to this individual? There is actually no effect whatsoever of the drug. And indeed, actually, and of course, there is no statistics here. This is pure observation because there is no power for me. I've done this in 1,000 patients. But in an N of 1, what you can see is that these patients with very high molecular complexity, you don't see the receptor. The question is, should I have actually used this drug in this patient where there is no reason why this drug will really work, as the patient does not have the target in the particular cellular compartment. This is the same data looking at the bone marrow mononuclear cells. If we had time to discuss this, you will see actually that the pathways that are triggering these patients are totally different from those patients that responded to therapy. And then finally, one example of how we can use this kind of technique for drug discovery. So Dr. Vera Adema, with actually Rashmi and with Dr. Simona Cola in our group, has been actually looking at this single cell data in quite a bit of detail, trying to figure out, for instance, what would be mechanisms of resistance to this kind of therapeutics. And they go actually and identify this molecular pathway that we call EIF2AK1, that is a kinase that basically triggers autophagy of these erythroid cells in the context of low heme. Basically, if you don't have enough oxygen bound to hemoglobin. And indeed, actually, what happens in myelodysplastic, as it happens in thalassemia and other disorders, is that this pathway actually is deregulated, pushing autophagy, basically cell death in a way, for those patients with what we call ineffective erythropoiesis. So this data now is allowing us to develop inhibitors of this kinase in an attempt to basically modulate autophagy as a therapeutic strategy in this group of patients. And with that, we have actually plenty of time for discussion, Dr. Kanagal, but I would like to finish here. So I hope that I convince you that conventional cytogenetics or karyotyping and NGS, if you have access to that and if you can afford that, are fundamental for the care of patients with myelodysplastic syndromes. This is very important to determine what the prognosis of your patient is, to predict response to particular therapy. So I gave you two extremes, right? NPM1, the P53, and very important in terms of deciding is your patient a good or not candidate for a stem cell transplantation. I also highlighted, I don't know if there are people interested on regulatory aspects here, but how important is to, when you do these assays that you're talking about, make sure that you can actually sample this through the course of the disease, not only one time, because they actually change with time, and you may actually change your therapeutic decision then. But then the reality is that this is going beyond what Dr. Kanagal and myself, small groups. Now you need like high-level computing, because what's happening? We're moving into what? Whole genome sequencing, very powerful cytogenetic technologies with this optical genome mapping. And now the question is, what happens with your BIF? What happens with the gene-to-gene interactions and so forth? So this is actually going to a scale that probably will need tons of centers, tons of patients, and a lot of computing data. And I personally would like to see the pathologist or the hematopathologist deploying single-cell genomic tools and RNA tools to help me see what's happening through hematopoiesis sequentially when I treat those patients. And I don't see, Rashmi, why this could not be in a few years in a CLIA environment. Why cannot I see, let me be rude, why do I need to trust you? Why cannot I see this disease in this kind of example where we can see every compartment, whatever the blast is, where is the mutation, what is the gene signature, and what therapy I'm giving is doing to those cells. I think that's basically the future, and I'm pretty sure we're going to get that. And with that, I'm actually really honored to be here, and I hope this was, from a clinical perspective, useful to all of you for whatever disease you are interested. So thank you, Dr. Kanagal, for the opportunity.
Thank you so much for that fabulous talk, for highlighting the importance of the work that we all do and how it directly impacts patient care, and also for giving us the overview of what technologies are out there and what we need to look out for to adopt into the CLIA lab to continue to make the difference. And now it's time for questions. If you can line up with the microphone, we also have virtual audience. Celeste?
Okay, hi, thank you for the wonderful talk, and it's always great to hear from a hemonc's perspective. I'm always challenged by this, where there are some labs that have produced major data that says that TP53 can be a chip variant. And I have a little, I always take back on that, because yes, I understand the data's out there to potentially line up that, but you also have to have the hemonc perspective of, was that properly seen in the clinical context that they actually didn't have anything, or that you didn't see anything. So if you had a patient who came in who had blood screening and found a TP53 variant sitting at maybe 5%, how do you look at it? How do you think of this in the context of that single patient?
This is really fantastic question. So I think there's three situations. I'll go very quickly so we have time for others. So occasionally, you will see patients with a lower BIF than that. Let's say 1%. I don't think they inform them, but you will tell me if it's below that. They may say, this is not, I don't know how you guys call that.
Validated.
But they will detect that in a context of clonal hematopoiesis. Actually, in the paper from Lachelle Weeks, they could not put those patients into the model because it had no prognostic impact. Actually, it's forced on the CHRS. It did not come. This has a particular therapeutic context that is not that frequent, but is not infrequent, very important. That is going back to this del5q minus MDS that I showed you with the lenalidomide. It turns out that some of these patients actually may have a low BIF P53 mutation clone. And in the past, data by Cambridge Group and Swedish shows that actually lenalidomide may promote the expansion of those clones. But now we're getting data from the Spanish group showing actually that in an early stage, early intervention trial where they treated with that particular drug patients with a low BIF, actually none of these patients really evolve or transform, at least through the course of the trial. I think this is very difficult for us because, to be honest, if I see that, it gives me a lot of anxiety as a leukemia physician. Now, I think once you have more than 5%, like 10%, 15%, now this is a reality. And you're posing a very good question. I don't have an answer. That is, should we actually treat those patients then? We're trying to do this analysis as we speak, that they may not have significant cytopenia, they may not have a lot of blast. Maybe the karyotype is not broken yet because they don't have, the P53 has not had chance yet to create a lot of genomic instability. But what if I treat those patients with a low BIF? Because indeed, actually, the transplant data suggests that you could cure some of them if you treat them with a low burden of the mutation. But this is all in transit. It's very complicated. So that's a really fantastic topic.
Thank you, because it's wonderful to have the hem-onc perspective on that.
Thank you.
I have a general question. So are these mutations occurring in pluripotent stem cells, or are they in a particular subcompartment where you would need to flow sort to do the mutation?
Yeah, this is a fantastic question. In MDS, most of these mutations come from a primitive stem cell. And that's why I think this European data showing total correlation is such. Now, this may not be the case in acute myelogenous leukemia. For instance, this NPM1 mutated, I think, is different in MDS versus AML, even if they call the same name now, because in the AML probably comes from a progenitor, so a branch-out cell, and you still have, healthy hematopoiesis on those patients. So that's why we don't need to do transplant. So in MDS, most of those mutations, they are in the primitive stem cell. And how do we know that? Because actually, if you look at mature neutrophils, you will find the mutation there in a majority of them. Thank you.
Well, my question is similar to Celeste's question about TP53. We have seen an increasing concern about the importance of clonal hematopoiesis in oncology, solid tumor oncology, right? Because we receive these patients with therapy-related myelodysplastic syndrome or AML. And what we have seen in oncology is an increasing use of neoadjuvant therapy. I mean, the patient doesn't have metastatic disease, but you give them chemo anyway, right? So, and we know that a subset of these patients will have TP53 mutations, and probably if you give chemotherapy, you're doing much more harm than what the benefit of solid tumor. Is there any initiative at MD Anderson to deal with this situation? I mean, have you had conversations with oncology teams or doing myeloid panels in patients that are candidate for adjuvant therapy to figure out what's best, how you deal with the patient in that situation?
This is a fantastic question. Actually, the Memorial Sloan Kettering has pioneered this because I don't know how they call their platform, but they have this data for many years. Now at MD Anderson, actually, what we call front door profile incorporates actually the CHIP mutations. That's why actually in our program, we're seeing a lot of these patients now. So we have the capacity to evaluate those patients with solid tumors that they may have some of these other mutations. So this is basically in transit. And then you pose another question that I don't think we have time to discuss that is very critical, that is this clonal hematopoiesis. People think that you always go from the solid tumor to the leukemia. But there's actually epi data suggesting that this is a two-street phenomenon, and we're curing a lot of our leukemia patients. Maybe not MDS, but we're curing majority of ALL, majority of AMLs, for sure all CMLs and so forth. And now we're starting to see an emergence, perhaps, of solid tumors that could be considered therapy-related solid tumors. So that's very interesting, and it goes back to this question of the epitopes and immune therapeutics that could be deployed in those group of patients. So that's where we are. Right now, we have the capacity actually to detect those patients, and they're actually informed into a clonal hematopoiesis clinic that we have in our department that basically captures those patients. There is a big grant called the BTC that is a consortium between MIT, Memorial, Dana-Farber, Hopkins, maybe I'm missing one program, where we're actually putting all this data together, and we're actually thinking about early clinical trials for this group of patients. This is actually already funded by a large donor who's interested on this. Thank you.
We have one question from virtual audience. How many mutations are considered as
this is very easy.
as high risk, and what is the VAF cutoff?
I mean, the VAF, I think, depends on the center, no, Rashmi? Like, you do 2%, I don't know what other people do. But the number of mutations will be 3 or more. And the more you acquire, the worse it will be. So that was easy.
Dr. Garcia, nice to see you in person at last after a whole year of Zoom calls.
Okay, thank you.
And have a comment about the UK data for the chip is that it's based on UK Biobank data, which the exome sequencing, which is 40x. So basically, they cannot call anything below 10% VF. So I wonder whether you guys have validated the same finding in like a pair cancer, that the peripheral blood sequencing, whether that actually can be.
We are actually doing that, and it goes back to the question that the colleague asked earlier. So what you're saying is that our level of detection is significantly deeper than the techniques that they use for this large-scale epi studies. So it's likely that we will see more of those patients through this front door protocol, or patients that we see with cytopenia. So you are correct. we just evaluated our first 100 patients with this condition. And it's very interesting because it gives you an idea of the power of the clinical context. So the UK Biobank could be this room. MD Anderson is only a cancer center. Actually, those patients with CHIP CCUS at MD Anderson, they actually die most frequently from the primary cancer that they have more than from the leukemia. So they have a totally different natural history. So it's going back to this issue of immune deregulation, neoantigens, epitopes. It looks like the better understood is actually, someone was asking about myeloma earlier, lymphoma myelomas, that they tend to relapse very quickly when these other myeloid clones emerge. So that's something that is very important, that this data is not the same. It's not the same going to Iceland and do the first CHIP study in that population, to this UK Biobank, to really go to a tertiary care center where everybody has cancer. The meaning of clonal hematopoiesis in that particular context is very different.
Also, the same study that you mentioned, the MCA, that also from UK Biobank study, but that actually, my observation for that data, actually most of the MCA they call actually from MBL instead of from myeloid.
Yeah, this is very interesting. So what, I'm sorry, I don't know the names, but the colleague is talking about the median corpuscular volume of the red cells. And this, preceding this study, there was a paper in Nature where they showed actually that if you follow these populations in time, the MCV, basically the diameter of those cells, expands with time. And actually that's, you're out of business, because actually that's the best predictor of developing one of these diseases, more powerful than having whatever mutation. Actually, my experience is that it really tracks the disease very well. So we have some patients with longitudinal follow-up where you see those MCV clones and the RWE also expanding, where actually they have disease later on. So yeah, there may be a very primitive, very simple way that could supersede everything that we're talking about here. I don't know. But please, I think this is important. A cancer patient may be different than a regular, healthy national population in some country. Thank you again, Rashmi, for your time.
Thank you, everyone. Thank you again, Dr. Garcia-Manero. And